Bismillahirrahmanirrahim. This is a case presentation of a patient with myocardial disease. Our patient is a 25-year-old gentleman who presented with an episode of loss of consciousness, which lasted for 3 minutes while he was watching TV. There was no prodroma and there was quick recovery after the episode. He had a history of progressive dyspnea for the past year, which was especially on exercise, particularly while playing football. This man has strong positive family history for hypertrophic cardiomyopathy, with his father having been diagnosed with hypertrophic cardiomyopathy in his 20s, and strangely he was implanted with a pacemaker in his mid-30s, which was later upgraded to a dual-chamber ICD a few years later. Unfortunately, this man died at the age of 43 during a VT storm. His aunt was diagnosed with hypertrophic cardiomyopathy at the age of 29 and developed VT. She was offered an ICD, which she declined, and unfortunately she died suddenly at the age of 32. His grandfather, on the other hand, was diagnosed with hypertrophic cardiomyopathy at the age of 48. However, he lived a long life and died at the age of 79 of stroke. His physical examination was unremarkable, and this is his ECG. Interestingly, there is left ventricular hypertrophy together with a deep negative T waves which are symmetrical in the infralateral leads. These suggest apical variant of hypertrophic cardiomyopathy. Notably, also there is a short PR interval of about 100 milliseconds. So, according to the ESC 2014 guidelines on hypertrophic cardiomyopathy, there are specific electrocardiographic telltale signs which can suggest specific diagnoses or morphological variants, with a short PR interval suggesting lysosomal storage diseases, mitochondrial diseases, or other rare genetic mutations like the PRKAG2 mutation, and the giant negative T wave, which is more than 10 millimeters. If I could show you, this is more than 10 millimeters, which suggests an involvement of the LV apex. And interestingly, the echocardiogram lends evidence to this prediction with an apical, with giant apical hypertrophy with normal septal wall thickness. Regarding the etiology of hypertrophic cardiomyopathy, there are diverse etiologies, and this figures from the guidelines, with the majority being sarcomeric protein gene mutation, about 60% of patients, mostly myosin binding protein gene, troponin genes, and myosin light chain genes, with unknown of 25 to 30%, and a small but important subset of about 10% of other mutations, like the MP kinase, which is PRKAG2, inborn error of metabolism, like the glycogen storage diseases, lysosomal storage diseases, neuromuscular diseases, and others. So, based on the clinical evaluation, including the family history, which is essential in these patients, together with the symptoms, ECG, cardiac imaging, including basically echo and potentially involving MRI and other investigations, we might find diagnostic red flags which suggest a specific disease. And in this case, we should go on to have further specialized tests and multidisciplinary inputs. If not, we could consider genetic testing to confirm diagnosis, as well as investigate the other family members, hoping to find a specific disease-causing sarcomeric protein gene mutation in order to trace other family members. So genetic testing, we had information already available from the father, which is myosin binding protein C positive and PRKAG2 positive. Interestingly, this patient had myosin binding protein C negative mutation, while he had PRKAG2 positive mutation. So, in contrast with the father, who had a quite malignant clinical course, who had a double hit mutation, this patient has only one mutation. The involvement of the PRKAG2 gene is interesting because these patients tend to have early on conductive disease, and this might explain why the father was implanted with a pacemaker in the first place. It also fits in well with the short PR interval, and this is an atypical form of disease. The guidelines do not tell us to treat these patients any differently than other hypertrophic cardiomyopathy patients, but we should be alert to the possibility of conduction abnormalities. And here are the recommendations for genetic testing in probands to identify the causative gene mutations so that we can trace the relatives. And in all patients with hypertrophic cardiomyopathy, there is a recommendation for beta blockers, even without LVT obstruction. However, it was decided to defer this until the issue of combustion enzymatic was sorted out. Further investigations were carried out, including the exercise treadmill test, which was negative, and a 72-hour ECG recording, which was also negative. And now we come to the sudden cardiac death calculator, which is used by the guidelines to recommend ICD therapy. And judging by his age, maximal wall thickness, which was 18 millimeters, plus atrial diameter, which was 39, having no outflow tract gradient, having a positive family of sudden cardiac death, having no unexplained syncope, because syncope will be explained shortly afterwards, and his age of clinical evaluation, his sudden cardiac death was just below the threshold for implantation, 3.9%, and it was recommended to implant a reveal link monitor, which after 1 month recorded an episode of Mobitz type 2 secondary AV block. It was implanted with a dual chamber pacemaker, and he's been well over follow-up of 1 year. So the guidelines have other recommendations to prevent sudden cardiac death in this patient. Of course, after implanting the pacemaker, the beta blocker could be added. In addition, all forms of competitive sport should be avoided, and he was placed under close follow-up for possible upgrade when need be to an ICD. Thank you for your attention.